Good morning, good morning, good morning. Oh, it's turned a bit cold again. I think the windy bends are open, so we'll go the windy bend way. That's all right. Yeah, so it's Friday morning. We're not working this afternoon. Let's get that window down. That's it. If in doubt, direct vision. So, how are you? All right? I trust you're well. Well, got just assorted jobs this morning. Starting at 8:45, finishing at 1. And then I've got someone staying overnight in the caravan, so I've got to go back and uh, get the gas working, get the water working. Electricity's already working. So hopefully do all that before it gets dark. So what can we talk about today? The hours that we work, they're pretty. I wouldn't say I'm semi-retired, but I have been. You know my philosophy, which is that there's no point working 5 days if you can fit all the work into 4. And with our aids for working from home, which is basically Vonage, which switches your phone calls through to a mobile, and Google Remote Desktop, which allows you to sit at home in front of a computer as though you were sitting at work in front of the work computer, and nobody needs to know that there's nobody in the surgery other than the fact that if someone rings up and says, "Can I come in today because I've got toothache?" You have to say, "No, I'm sorry, not today, but tomorrow." Hello, madam. Yes, sorry, you had to move to a village that doesn't have any footpaths. I sympathise with you. So we're making some changes to the hours. I mean, that's a great thing about owning your own practice. You can be your own boss, in general. You can make decisions to suit yourself. So what's happened is that, I take my grandchildren to school. I have to get them there for 8:30, 3 days a week. And then I've been asked if I can also pick them up. And so they come out at 3:15. So obviously it's quite difficult to, you have to take the afternoon off, don't you, if they're coming out at 3:15. Or in my case, finish at 2. So what we're going to do is we're going to start. Someone's got a new dog that won't stop pulling. Yeah, we're going to start at normally what the hours I swear by, and you should do too, are get the staff in by 8:30 and start the clinical session at 8:45. That way you get an extra 15 minutes start on your 9 o'clock work day, and 15 minutes is all the staff need to turn everything on and set everything up, because they'll have left it ready to go the night before. So, but then if you're going to finish at 2, then there's no point. I mean, if you have a lunch hour, then you'd finish at 1, wouldn't you? And then just not start again. So we've decided to work from 1 to 2. So it means that they're going to be working from 8:30 till 2, which is 5.5 hours, isn't it? But I mean, we don't work. How can I put it? I mean, there's plenty of chances for cups of tea and stuff like that during that time. Bearing in mind that we book, your average checkup is booked in for 45 minutes or half an hour minimum, and not the 5 minutes that we used to book when I worked on the NHS. So So, but what that means is that obviously because we're sacrificing 2 hours, 2 hours, 3 hours on 2 or 3 days, or 2 days, that means we've got to make up those 6 hours some other time. So what we're going to do is we're going to work every Thursday, which was the day that we occasionally took off on full pay, mind you. But it means that they will have to come in. So instead of having 6 hours Thursday off on full pay, they're going to have 6 hours off in 2 3 hour slots on Monday and Tuesday afternoon on full pay. So it's just basically a shuffling of the block puzzle, shuffling of the blocks in terms of time off. So now you could say that, I mean, perhaps some staff would kick up a stink about having 2 afternoons off instead of one whole day. But my staff is absolutely brilliant. They really are very much whatever it takes, to keep the surgery going in a way that's the most efficient. Yeah. Here we go. Okay. Round one lorry. He's pulling in there, isn't he? Where they're building the house. And I'm stuck behind the bin lorry now. Well, why not say stuck behind? He's actually not exactly hanging around, is he? And the other thing that happened was we had a chap who wants quite a big job done. He's got a full upper, but he's got 10 lower front teeth. And the 2 5s have drifted a long way distally. So much so that on the right hand side, I'm going to do a 3-unit bridge from the 4 to the 5 with a pontic in the middle. And on the left side, I'm going to do a 4-unit bridge from the 4 to the 5 with a pontic in, 2 pontics in the middle. And I wouldn't, normally I wouldn't do a 4-unit bridge from a 4 to a 5. But it's up against a full denture, so really we're not talking about a lot of occlusal force here. So that's why I said I'm very happy to do it. And it's a funny case. He went to Turkey and said he wanted implants, and because he's on bisphosphonates, which are bone strengthening drugs, they said they wouldn't do it. They wouldn't do implants. In he goes, going to pick up all the rubbish from the caravan park. So he's come back to the UK and wants a quote, and I've told him how we can do it with bridges, and he's a bit overclosed as well, which just means his nose is too close to his chin, so it gives him a sort of a prematurely aged appearance, which at the age of about 50, whatever he is a bit unfortunate. So I think with the reason why we do so many, well, not so many, we don't do a lot of them, but I mean we do quite a few of them, these large cases, is because we can sort of talk to the patients in a way that they want to be talked to. What I do is and also another trick is not to do it in the surgery. So when they come in, we've got a desk, and I sit where the receptionist sits, and they sit the other side, and we just have a chat, mano a womano or mano a mano, over the desk, and it's far less confrontational and less threatening. They're not worried that I'm going to suddenly jump on them with a mirror and probe. So they just have a chat and say, and we try and find out what their objectives are. In an ideal world, what would you like to do? What would you like us to do? And they can do it in a relaxed format, and we make sure they know it's under no obligation, and that doesn't matter what we discuss, how complicated, and they don't need to remember it, because we will write it all down for them and email it through to them, and they get that the same day. I mean, sometimes they get it within half an hour. So they pretty much remember, and we always summarise what their problem is. Like, so for example, you've had a pain in a lower right molar or a lower left molar, as it was yesterday, and it hurts every time you bite on it. And sometimes it's worse than others, but it's quite a sudden pain, and not a very bad pain, but persistently there. It's been there for months, and you went to see your NHS dentist, as they did in this case, who x-rayed the tooth and said they couldn't find anything wrong with it. And I said, our diagnosis is, based on the fact that it's a bit tender to tap on, that you've got a crack under the filling, which is quite common with very, very old amalgam fillings. Here's a little tip from someone who was putting fillings in those days. A lot of dentists use very cheap amalgam. Amalgam was pretty much all we had in the early 80s, and obviously the NHS dentists bought the cheapest amalgam they could buy, that was compatible with the Dental Estimates Board's requirements for materials. And obviously the thing that was scrimped on was the silver. They put as little silver in it as possible and filled it out with a load of other silver looking metals, but didn't have silver's properties in terms of corrosion resistance or lack of expansion. So the cheap silver fillings were still good, but what we found is that over 30-40 years they've oxidized, they've corroded, if you like, around the edges and expanded, and that's led to a lot of cusp fractures. Bearing in mind the tooth's a bit like a hot cross bun. It's divided into 4 segments usually, especially the lowers, which are the ones that crack, and so what happens is 1/4 of the tooth cracks off, usually the inside back, the distolingual cusp. Let's get round here. So and then I have to explain to her what, having sort of diagnosed the problem which the other dentist missed, you then have to explain to them what their options are, which are obviously the first option is to do nothing, which I always say is what you've been doing up to now, so that's fine. Or the alternative is to take the silver filling out and have a look and see if we can find the crack, which we almost can do. You can't see these cracks on x-rays unless they're completely in line with the x-ray beam, and that for a coronal crack, amalgam related fractured cusp, that's very unlikely. It's more likely with someone who's had a blow to the tooth where it's snapped across, and so then occasionally you can see that on the x-ray. But if it's an oblique fracture in any way relative to the x-ray beam, then you won't see it. So we took an x-ray, and sure enough, like the last dentist, there's nothing to see on the x-ray. But unlike the last dentist, we didn't just say, no, I can't see anything wrong, go away. We said that the provisional diagnosis, which is, believe it or not, is something I had to explain to the General Dental Council last time I was called as a witness to fact. They did not have a clue what a provisional diagnosis was, and I had to explain it twice. I presume to the lay members, but you do get a bit cross, because they have got, not only have they got dentally qualified members on the GDC disciplinary panels, they've actually got experts. They've got access to expertise, to expert advice. So there's no way like a general dentist like me should be having to explain to the disciplinary committee what a provisional diagnosis is. Anyway, let's just concentrate. We should get quite a few boy racers around these roundabouts, like that one, BT15 Tango Zulu Charlie. They come round the roundabout like they're cornering at the Nürburgring. Anyway, so you take the filling out and then you have a look and see if you can find the crack. You can. And then your options are then you can put a white filling in, which is bonded in. And so you would expect it to sort of hold the tooth together a bit better and perhaps alleviate the symptoms by preventing the tooth from sort of flexing when you bite on it. But the other thing you have to do is reduce the cuspal height. You have to reduce the height of the tooth, especially on the affected cusp. In fact, I wouldn't worry too much at all about literally taking the affected cusp almost down to nothing, because there's two types of fractures. There's vertical fractures and there's horizontal fractures. I mean, obviously there's a lot in between, but the point is, the more near a horizontal fracture it is, the better, because then a lump of the tooth falls off, and you're able to say to the patient, yes, we can build it up again, or we can crown it, or whatever. Whereas if it's a vertical fracture, as I had in my upper lip 6, where we'd had a very deep MOD, amalgam, and which had probably expanded, and then I've got quite a strong bite still. Just split the tooth in half vertically, at which point there's nothing can be done. So it's better really to crown the tooth, but you have to crown it when it's symptomless. There's no point saying to the patient, oh yes, you've got a twinge, we think it's a crack. I'm just going to leave your silver filling in, and then and stick a crown over the top of it, and the crown will hold it all together and act like a crash helmet and protect it and strengthen it and make it look nicer, etc., etc. Because you're asking then for a patient to come back after about a month saying, that tooth's still painful when I bite on it, and it may be because it had, like, it's got 3 roots inside it and one of the roots was dying off or something, and then you find yourself having to do a root treatment through the crown. So really you do have to take the filling out and diagnose the problem. And then you've got the problem of the patient doesn't want to pay twice, because if you say to them, oh, you can either have a filling or a crown, basically you then turn around and say to them, yes, but we have to do the filling first to check whether you need a crown. So, it's difficult, isn't it? Those are all the issues, and that's just over one patient who came to us from another dentist who couldn't find a pain that was not really there all the time and was not a massively painful or a big problem or anything, but just all the issues that played into that single cracked tooth. Do you know what I mean? So anyway, we've got this chap coming in who needs all the crowns and bridges, and his lower teeth are quite worn. So what I'm going to do is I'm going to do linked crowns. So I'm going to link the lower right 1, 2, 3 and the lower left 1, 2, 3. So that'll be a 3-unit, 3 abutments basically on the bridge. They're redeveloping this junction. I can't say I blame them, because the cars that are in front of us can't see the cars that are coming from the right of them to the left of us because of the bend in the road. So if I pull out slowly, he's going to know there's nothing behind me, and he's going to know there's nothing coming. That's lot on the left there, they're the disadvantaged lot. I don't know what they'll do. They'll probably put in a small roundabout, but it'll take them 2 years to do it, and all the time. Also, they're trying to redevelop this airfield for commercial freight. So, and that's going to happen over the next 2 years. So I should imagine they'll need a decent roundabout there. It hasn't got a train station. There is a train station sort of half a mile away, but not good enough to walk your bags to the terminal. This land on the right here is where the terminal is going to be, the bit we just driven past. The big old, that's the old terminal on the right over there. That's where I learned to fly. yeah, so anyway, he can't really come in. He works all day, so basically he needs to have an afternoon off to come in and get all this work done. So, like I say, well, I've got a 4 unit bridge on the lower left 4 and 5, two 3 unit sets of link crowns on the 321 and the 123, and then another 3 unit bridge on the lower right 4 5. And we're doing that all in one session. That'll be okay to do that. The thing to do is to make sure you get a really hot impression of the teeth before you file them down. So well, I certainly wouldn't do it in alginate. Doing something like that, rubber base. And then the good thing about rubber base is if it's not absolutely brilliant, you can squirt a bit of fine-bodied rubber base inside your existing impression and stick it back on, and then when it comes out the second time, it will then come out perfect. And then you keep that in the cupboard, because in the unlikely event that any of your temporaries come off, you can use it to make new ones. And also the temporaries that you make by squirting some temporary crown material inside a rubber based mold that's really pretty perfect means that the patient can come in and go out with the same teeth. They go out with the same teeth they came in with, which is tremendously reassuring for them. Not only that, it makes very good temporary crowns. So they don't think, oh, and like if you put an aluminium temporary crown on a tooth, most people will be, okay about it. But if you're charging a lot of money for a crown, you might as well it all depends on whether the tooth is there in the first place. You know what I mean? If the tooth's there and it's pretty much the right shape, then I would send them out with a white rubber based temporary crown. If it's in the right state, if it's in a right state and then you have to build it up with a core or something, then I don't mind putting an aluminium temporary crown on it if it's at the back. Certainly a lower molar, for example, they're very easy to make. You have to cut them to length, and then you have to bend the edges in with some crimping pliers, and then what I do is when they're a pretty tight fit, I just put them on and get the patient to bite on them, and then stick them on with some Cavit. Cavit is very strong now. It didn't used to be this strong, but Cavit is really strong now. You'll have trouble getting an aluminium temporary crown off if it's been stuck on with Cavit. But the good thing is that you can get a Mitchell's trimmer underneath or a Hollenbach carve or something, and just try and just work your way underneath the buckle margin and literally cut the crown like with tin snippers. Cut it up and over the top, and then it'll come off. But 9 times out of 10 they should flick off. The one tip is, if you're going to use like a flowable composite or some sort of dual cure core build-up material, don't put an acrylic crown over the top. Rather a methacrylate crown. One of these ones that comes in a little pot, and you take it out and trim it up and stick it on and cure it with a light. On dentine they're very good, and I do use them, but on core build-up material they will literally just fuse to the core, so you can't then get them off. So no amount of pulling or whatever's going to get them off. So then in those cases it's a good idea to use a very white core material, because then you can tell when you're drilling your temporary crown off where you need to stop. Alright. Well, that was very top heavy, wasn't it, clinically? So we've booked from 4 till 7 for him to get that lot done, and it shouldn't be too tricky. We've only got to take an alginate of his upper denture, which I think we've already got. We took a mould of his lower teeth for a special tray. That's right, yeah, and we've mounted the teeth on an articulator because we want to open the bite a millimetre or two. Although we're going to do that about a millimetre on the crowns and bridges, and the rest of it on the denture, because he's not really showing his upper front teeth. So we'll do something with that as well. Move them downwards and forwards a bit. So it's a nice job, and we don't mind working till 7. That's the good thing about my staff. As I say, they're absolutely brilliant. They're like, yeah, coming to work at 2, go home at 7. It's only one day, you know. And the receptionist in particular said that when she used to work in Boots, they used to work till 7 o'clock every day. So for her, just working, you know, not starting till 2 and working till 7 is half a day off. Anyway, all right, I hope you're well, and I'll talk to you soon. Bye.